Welcome to the Deep Dive. We're here to give you that fast track to essential medical insights.
That's right.
And today, we're really zeroing in on a pretty high-yield topic for anyone doing MSRA revision, femoral hernias.
Definitely high yield. Think of this as your kind of streamlined guide. We want to get you up to speed efficiently.
Okay, so we've gathered the key info, haven't we? Definition, causes, risks, how they look, how to manage them, the works.
Exactly. The mission is to pull out all that crucial stuff you need for revision, make it stick.
Right, let's dive in then. First things first. What actually is a femoral hernia? Give us the core definition.
Okay, so generally a hernia is, abdominal contents poking out where they shouldn't. For a femoral hernia specifically, it's those contents, maybe bits of intestine, maybe just some fatty tissue pushing through the femoral canal.
Femoral canal, right. And location is key here.
Absolutely key. It's in the groin, crucially, below the inguinal ligament. That's the defining feature.
Below the inguinal ligament. Okay, that needs to stick. Any tricks for remembering that?
Yeah, simple one. Just think below inguinal, femoral. Say it a few times. BIF. Below inguinal femoral.
BIF. I like it. Below inguinal femoral. Okay. So why does this happen? What's the root cause, the etiology?
Well, fundamentally, it stems from a weakness,
right?
A defect, or just a weak spot in the wall of that femoral canal.
A weak spot.
Yeah, but it's usually not just one thing. It tends to be multifactorial. So you've got that inherent anatomical weakness combined with things that increase pressure inside the abdomen.
Okay, so a weakness plus pressure makes sense. What kind of things increase that pressure or, predispose someone to the weakness?
Yeah.
That takes us to risk factors, doesn't it?
It does, yeah. And there are some pretty clear ones. First off, being female, it's much, much more common in women.
Right.
And here's that memory link again. Think F for femoral, F for female. Helps lock it in.
F for femoral, F for female. Useful. What else?
Well, getting older, so advanced age, tissues just lose a bit of strength,
Sure.
Obesity is another big one, more pressure. Pregnancy, too, for similar reasons, pressure and stretching. And finally, think about connective tissue disorders. Something like Ehlers-Danlos syndrome, where there's just generalized tissue laxity, that can definitely predispose someone.
Okay, so female, older age, obesity, pregnancy, connective tissue issues. Got it. Now, how does it actually happen? The pathophysiology.
It's fairly straightforward, really. You've got that weak spot, that defect in the femoral canal.
Yeah.
Then something increases the pressure inside the abdomen. Could be coughing hard, straining, lifting something heavy.
Right.
And that pressure forces the abdominal contents, like intestine or omentum, through the opening. They basically follow the path of the femoral vessels, which run through that same canal.
Like finding the path of least resistance.
Okay.
Now, clinically, someone comes in with a lump in the groin. This is where it gets tricky, differentiating it, right? What are the main differentials?
Oh, absolutely critical. That groin lump could be several things. Top of the list is usually an inguinal hernia, much more common overall.
Inguinal, right? Direct or indirect?
Both, really. You need to consider direct inguinal hernias, those push straight through the abdominal wall weakness, and indirect ones, which follow the inguinal canal.
Okay.
But, and this is vital, you must consider an incarcerated or strangulated femoral hernia. Recognizing those is an emergency.
Huge point. What else should be on that differential list?
Definitely lymphadenopathy, swollen lymph nodes. You might think about a hydrocele, but remember the trick there is usually you can get above the swelling, separating it from the groin structure.
Okay, the get above it test.
Exactly. Then there are things like a spermatic cord hydrocele, maybe a psoas abscess or a bursa, the saphena varix, that's a dilated vein near the saphenous opening.
Saphena varix.
Varicocele, though usually lower down in the scrotum. And even just, some bleeding or a hematoma.
That's a good list to keep in mind. Okay, zooming out a bit, What about the numbers? Epidemiology. How common are these, say, in the UK?
Okay, UK figures. The incidence is around 7 per 100,000 person years. Not hugely common, but significant. Prevalence, as we said, higher in females. It tends to peak in the 50s and 60s. And overall, femoral hernias make up maybe about 5% of all abdominal wall hernias.
Only 5%. That does put it in perspective against inguinal hernias, for example.
It does. And that gender split, the male-to-female ratio is roughly 1:3. So 3 times more common in women.
Wow.
Especially noticeable in women who've had multiple pregnancies. That repeated strain, you see.
Makes sense. And age-wise?
Mostly middle-aged and elderly women. They're actually quite rare in kids.
Interesting. And didn't you mention something about elderly women specifically?
Yes, that's right. In elderly women, the incidence of femoral hernias starts to approach that of inguinal hernias. So it becomes relatively more common in that specific group, something to remember.
Good point. Okay, so we know who gets them. How do they typically show up? What symptoms and signs are we looking for?
Often it starts with groin discomfort or maybe outright pain, and characteristically it gets worse with anything that raises intra-abdominal pressure.
Like coughing, lifting.
Exactly. Coughing, lifting heavy things, straining, that sort of thing. They might also notice a swelling, a lump down there.
Right.
And that lump could be reducible. You can push it back in gently, or it might be irreducible, stuck out. Sometimes it's just a visible bulge they notice.
And on examination, what are the key things to feel for or look for?
Well, you're looking for that lump in the groin area. It might be only slightly tender initially. The absolute key is pinpointing its location relative to the inguinal ligament. Remember our mnemonic?
Below inguinal femoral BIF.
Precisely. Femoral hernias are often non-reducible. You might still feel a cough impulse when you press on it and ask the patient to cough, though.
Okay.
And then you need to classify it. Is it reducible? Irreducible? Is it obstructed, meaning blocked? Or the worst case, is it strangulated? The classification is really important.
Vital, especially spotting strangulation. So how do we confirm the diagnosis? What investigations are standard?
Honestly, the diagnosis is primarily clinical. A good history and careful examination focusing on those physical findings often gets you there.
So hands-on assessment is key.
Absolutely. But ultrasound is a really useful addition. It's great for actually seeing the hernia, seeing what's inside it, and confirming the location.
Okay. What about fancier imaging? CT, MRI.
Yeah, sometimes. If the diagnosis is still murky after clinical exam and ultrasound, or maybe you need more anatomical detail for planning surgery, then CT or MRI might come into play.
But mostly clinical plus ultrasound.
Mostly clinical, strongly supported by ultrasound, and always rule out those other causes of a groin lump we talked about.
Right. Okay, diagnosis made. It's a femoral hernia. What's the plan? How do we manage it?
Well, if it's symptomatic, causing pain or discomfort, the standard approach is elective surgical repair. Get it fixed before it causes major problems.
Elective repair. But what if it's already a problem, like incarcerated or strangulated?
Then it's a different ballgame. Incarcerated, stuck, or strangulated blood supply cut off, that's a surgical emergency, needs urgent, immediate surgery.
Okay, emergency surgery for those. And the type of surgery? Open. Laparoscopic.
Both are options. Repair can be done laparoscopically, keyhole, or via a traditional open incision.
Is there a preferred method? Or specific recommendations?
Yes, the strong advice is repair all femoral hernias electively. Don't wait. The risk of strangulation is just too high.
Right, fix them proactively.
Exactly. And generally, mesh repair is recommended, especially if the surgical team is skilled in laparoendoscopic techniques.
Why mesh?
The evidence points towards mesh repair, especially the laparoendoscopic approach, giving lower recurrence rates, less chance of it coming back.
Lower recurrence, okay.
Open surgery is still fine, obviously, if needed. And if mesh isn't suitable for some reason, they can use stitches, a suture repair.
Good to know there are options. And the outcomes generally?
Generally good. The risk of complications like bowel obstruction after the repair is low, and elective repair itself has very low mortality.
That's reassuring. So, overall, what's the outlook? The prognosis?
On the whole, surgical repair worked well. Recurrence rates are low. So, with the right management done in good time, the prognosis is favorable.
But there's a but, isn't there? Related to strangulation.
There is, and it's a big but. Strangulated femoral hernias, they have a much higher risk of morbidity, serious illness, and unfortunately, mortality. The outcome is significantly worse if it gets to that stage.
Which really underscores the importance of early repair.
Yeah.
Let's talk about those complications then. What are the big dangers we need to revise?
Okay, the main serious ones are incarceration, where the tissue is trapped but the blood supply is okay for now.
Stuck but not dying yet.
Kind of, yeah. And then strangulation, that's the really dangerous one. The blood supply is compromised, tissue starts to become ischemic, lacking oxygen, and can necrose or die.
Ischemia and necrosis. Bad news.
Very bad. And if it's bowel that's trapped in either scenario, you can get a bowel obstruction as well.
All right. And you mentioned earlier the risk of strangulation is particularly high with femoral hernias. Higher than inguinal.
That's a key point, yes. Definitely higher. It's thought to be because the femoral canal is quite narrow and has rigid boundaries. It doesn't take much for the contents to get squeezed tightly.
A tight spot.
Exactly. Unlike the potentially wider inguinal canal. And the longer someone has the hernia without repair, the higher that strangulation risk climbs.
How does a strangulated hernia present? What are the red flags?
You're looking for acute signs. The area will likely be red, very tender. The lump itself will feel firm, and it won't be reducible at all. The patient might have severe abdominal pain. Their abdomen might become distended. They might be vomiting. It's a full-blown surgical emergency picture.
Redness, tenderness, irreducibility, abdominal pain, distension, vomiting. Emergency bells ringing.
Absolutely. Get them to surgery fast.
And missing this diagnosis.
Yeah. Unfortunately, failing to spot a strangulated femoral hernia correctly or quickly enough, it does happen.
Yeah.
And it's linked to a much higher chance of needing bowel resection, cutting out dead bowel, and sadly, a higher risk of death.
Wow. Okay, that really drives home why this is critical knowledge for the MSRA.
Yeah.
So let's just quickly recap this deep dive.
Good idea.
We've defined a femoral hernia. Protrusion below the inguinal ligament. Remember BIF?
Below inguinal femoral. Yep.
We talked about the causes, that weakness plus pressure. Risk factors, female, older, obesity, pregnancy, connective tissue stuff, pathophysiology, contents pushing through that weak canal, differentials, inguinal hernia is key, but also lymph nodes, hydrocele, etc.
Don't forget incarcerated or strangulated itself on that list.
Crucial point. Epidemiology, more common in older women, about 5% of all hernias in the UK.
Right.
Clinical features. Groin lump or pain, worse on straining, maybe irreducible. Examination is key for location.
And classification, reducible, irreducible, obstructed, strangulated.
Investigations. Primarily clinical ultrasound is very helpful.
Yep. Management. Elective repair for pretty much all of them to prevent strangulation. Urgent surgery if it's already incarcerated or strangulated. Mesh repair often preferred.
Low recurrence with mesh, especially lap endo.
Prognosis. Generally good with repair, but much worse if strangulation occurs.
Which leads to the complications. Incarceration, strangulation, bowel obstruction, all serious, especially strangulation due to that high risk in the narrow femoral canal.
Okay, excellent summary. So here's a final thought for you to mull over as you revise. Really consider how that specific anatomical spot, the tight femoral canal, below the inguinal ligament, and that inherently higher risk of strangulation compared to other hernias, how that directly impacts the clinical urgency.
Yeah.
Why we need to be so vigilant.
That's the core message, isn't it? Anatomy dictates risk, risk dictates urgency. And for more top-notch revision resources, definitely check out FemoralHernia.com.
And don't forget FemoralHernia.com as well, both fantastic sites to support your MSRA journey.